Yay, got it. Okay.
On October 22nd, 2023, the airwaves and internet were ablaze with controversy as world-renowned Dr. Joseph Mercola unleashed a podcast and blog titled What You Need to Know About Estrogen and Serotonin. With his immense influence on one of the most visited health blogs on the web, the ripple effect was staggering. But what ensued was more than just a discussion. It was a collision of misinformation, sparking outrage not only from myself and my guest today, but also from numerous other hormone practitioners around the globe. Today, we are going to delve into the heart of this storm with a sense of urgency and determination. As my guest today said, I was appalled at how much of it is massively wrong, not based on hormonally driven peer review science. Worst of all, he does a stunningly huge injustice to our natural hormone therapy cause. With us today to set this record straight is one of the foremost experts in the field of hormones, whose guidance has been instrumental in shaping my own journey to becoming a hormone expert, Dr. Devaki Lindsey Berkson. Dr. Berkson is a thought leader in functional medicine with an emphasis on hormones, nutrition, digestion, and intimacy. She was a distinguished hormone scholar at a world-renowned estrogen think tank at Tulane University because she wrote one of the first breakthrough books on endocrine disruption. Dr. Berkson wrote the first gut nutrition spirituality book, Healthy Digestion: The Natural Way, which was a bestseller. She has taught relicensing seminars to professionals and formulated the first female nutraceutical line for physicians in the US. She is often a keynote at prestigious medical and pharmaceutical symposiums. Berkson is credited with an in-depth knowledge of estrogen vindication and has an ebook on hormones for breast cancer survivors at drlindseyberkson.com, as well as written my top recommended book on HRT for women that I believe every woman needs to read, titled Safe Hormones, Smart Women. Dr. Lindsey stands out as a beacon of knowledge and advocacy, earning not only my admiration, but also my deepest respect for her unwavering commitment to enlightening the global community about hormones and debunking the myths surrounding estrogen. So, welcome, Dr. Lindsey. I'm so happy to have you here.
That was a really great introduction. I'm going to have to get a copy of that and pass it out every time I do other shows. That was very well done. I could see why you're as successful as you are. And I
Thank you.
appreciate the opportunity to have narratives and conversations like this to kind of try and set the hormonal landscape straight.
Yes. And when that article came out, I actually learned that it came out because I'm part of your newsletter. And so when I read that and I went onto his site, I was so shocked and so angry with it. And I was so glad that you put out this rebuttal to it. And it was like your newsletter was like, I've been up since 4:30 in the morning composing this blog as a rebuttal to this. And I went on to his Dr. Merkla's Instagram. And it was so awful because the comments, I don't know if you read them, but it was hundreds of women going, I'm getting off my estrogen. I am so glad I've read this. And I'm so glad I listened to this podcast. And I'm thinking, oh my goodness, what have you just done? So let's talk about this and just in general, because a lot of the stuff that they talked about, him and his guest, are things that many women still believe and many medical practitioners still believe. And where does this come from, Dr. Burks? Why do we have so much fear surrounding estrogen?
Well, I want to dive into where we went astray with estrogen, but I want to set the scene straight because, we all know what we focus on. And Dr. Mercola has done a lot of good in many things that he's done, but he was only in practice for 2 years. He's basically a marketing guy. He basically sells information and sells products. He's a big deal about selling products. And part of my issue with the massive misinformation and him interviewing this, not a clinician, but somebody who was a scientist that had his own opinions, which were wrong on estrogen, within the body of that, Mercola was really launching a new DHEA product. So I had to take a few steps back and take a look at this as an infomercial, a wrong infomercial. So that there were so many layers of it. You know, he is not a hormonal doctor, but and you know, there's a lot of people who aren't hormonal doctors because in med schools, osteopathic schools, naturopathic schools, we no longer really teach hormonal medicine other than birth control pills and maybe estrase and estradiol patches and so forth. So let's take a look in a nutshell at how we got so wrong about estrogen. And let's talk a little bit about vindicating her and making her right. So Britain was the first country that came up with the idea, although way back in the Chinese emperor times, they took urine from young, healthy boys and girls, teenagers, and they actually made herbal hormone urine balls because you get your estrogen and testosterone, et cetera, metabolites in urine. And they used those as anti-aging. Those were really the very first bioidentical hormones were the Chinese urine balls. But coming forward to modern times, Britain within the 1950s started using estrogen replacement therapy. And the promise of the education to the female patients were that you would be more feminine forever. And it was very good for your heart and very protective in general. So women were being prescribed estrogen therapies after stints were put in, if they had congestive heart failure, if they just had a heart attack. They were being given hormones. They were very, very big. And coming up toward closer to the 2000s back in the United States, whatever happens in Britain and in Canada often happens in the United States because the three of us are such close, you know, brotherly, sisterly countries. So by the year almost 2000, almost 20 million American women were on hormones. But in the United States, women aren't on the same kind of hormones that Britain was writing scripts for, which were natural estrogen like estradiol, or a milder form of estrogen called estriol. Instead, in the United States, the products available to women are patented products so that the molecules, the left-handedness, right-handedness, the shape of the molecule, we call it the chirality of the molecule, is altered a bit so that it could be patented for the people that own stock in those companies, but they're not exactly the same as natural hormones. So the United States is an aging country. I don't know if Canada's kind of catching up with us, but it's theorized that by 2030, 65% of Americans will be over the age of 65. So the concern is, will we run out of money for our healthcare system for our elderly, which is called Medicare, and people in the US get on Medicare at 65. And everyone's worried we're going to run out of money for Medicare. So we decided to, keeping that in mind that we're an aging country and 20 million women were on estrogen, let's form something with 40 prestigious institutions, including Harvard and trickling down to everybody else that are big dudes and institutions in the United States. And we're going to form something under the auspices of our major National Institute of Health, the NIH. So it was called the Women's Health Initiative. And this was really just to say, women live longer than men. They live a third to a half of their life in menopause. We've got all these aging women. How are we not going to run out of money to take care of their health? So let's see what works and let's see what doesn't work. And the very first thing we should probably test out is hormones. So there was an arm that gave hormones only, but in the United States, it's pregnant horse estrogen urine called conjugated equine estrogen. And then they had a combo arm where they gave exactly that same pregnant horse estrogen. CEE is the abbreviation, along with a synthetic version of our natural progesterone, so it could be patented, called synthetic progestin. So one arm had horse swallowed estrogen and the other arm had horse swallowed estrogen with synthetic progestins. And both arms were supposed to run for about 8 years, but early on, the combination arm was stopped early because they thought that they were seeing a few more cases of breast cancer and heart issues. So they stopped that combination arm. And that's where the WHI got its bad reputation, was stopping that combination arm that had the synthetic version of progestins, which, for example, all oral contraceptives are made of progestins and then a synthetic estrogen, ethinyl estradiol, if that's added. And there are no studies that do not confirm that oral contraceptives increase your incidence of breast cancer while you're on them, and often for duration of so many years, even when you go off of them, because of the synthetic progestins. When the estrogen only arm was monitored, it was monitored within a few months by Leon Spiroff, who is the iconic gynecologic professor. He used to be a professor at the University of Oregon, and he writes the books that all of us weaned on in any kind of med school that you go to at all, Fertility and Gynecology by Leon Spiroff. He said, don't throw the hormonal baby out with the hormone bath. Then NAFTA statisticians, women get less breast recurrence. If they do get a recurrence, they die less from it if they were on estrogen. They kept reevaluating the estrogen only arm all the way up till 2019, when in December, every December in Texas, I'm in Austin, Texas, a town called San Antonio, and every December, breast cancer researchers get together for a San Antonio Breast Cancer Convention, and they share a lot of data to try and keep women safe. They shared the 19/20-year reanalysis of the Women's Health Initiative by the original authors of the Women's Health Initiative, and they said nothing has ever been so breast protective as estrogen. Estrogen, if you're on it for 5 years, on average, because that's when they stopped, and they only stopped the estrogen only arm because they thought they were seeing a slight increased risk of heart issues because the hormone was swallowed, and we don't recommend swallowing estrogen. But when they tracked for breast cancer, which is what everybody's worried about, at the 20th mark, they said women who had been on hormone estrogen for an average of 5 years had a decreased incidence of getting breast cancer by 23%. And God forbid if they got breast cancer, if you were on estrogen, it wasn't that estrogen gave it to you or made you worse. It actually made your scenario better. You had a 44% decreased fatality incidence, meaning you had 44% reduction of dying from breast cancer if you get it, because women who take estrogen and then they get breast cancer tend to have a less aggressive, less fast-growing, etc. form of cancer. This never made headlines. It never made headline news from the very same authors that initiated it. So we call this 20-year reanalysis the WH2 because it's the reanalysis by the original authors. And now that research has been replicated over and over and over again. There are some studies that do say that estrogen drives breast cancer. But if you read those studies, which are not as many of the studies that say that it protects, if you read them, the majority of them are done with hormones that have synthetic progestins or a variety of other issues. And medicine is all about the trends. It's often that there's one study that says this, another one says that, but you wait over 10, 15, 20 years and say, what are the trends and where's the heaviest weighted directionality of all the science? The directionality is that estrogen protects breasts, and it does much more. And what's coming out right now is the largest study ever run on hormones in the world. And that study is called the 7 million study by the Medicare study by the American NIH and National Library of Medicine. And they looked at 7 million Medicare patients, which they have all their records because they're on Medicare. So at that point, when a woman turns 65, the government is paying for her health. So the government has all her records. And they looked to see that there were 1.5 million women on estrogen. So they said, okay, let's dive into the records of 1.5 million women. That's amazing. So they looked at how long they lived. They looked at which way they took the hormone into their body. They looked at how much hormone they took in their body. They took a look at 5 cancers: breast, ovarian, uterine, colorectal, and lung. They looked at adverse cardiovascular events like stroke and heart attack. They looked at neurodegenerative issues like, do you keep your cognition and your wits about you or no? And they discovered that if women had been, again, it completely echoed the results of the WH2, the reanalysis at 20 years. If women had been on estrogen for an average of 5 years, any time in the history of their health, they had statistically less of all of those 5 cancers they looked at. Breast was at the top. Every single woman took in estrogen, protected her breasts. Exactly the same statistics that we saw in the Women's Health Initiative that never made it out to the public, and that for some reason people are saying that showed you that estrogen is bad when it actually showed you that estrogen was good. Women live 20% longer, and the other shows is that even older women with cardiac disease, like originally seen in Britain, women with cardiac issues who have congestive heart failure, they're suffering, they have a history of a stroke, a heart attack. These women live longer and better if they went on estrogen. Whereas today in the United States, high-risk women are told you are not a candidate, but the science is not supporting the way that doctors are being educated. So I hope I Vulcan mind melded that in a manageable set of sound bites.
Oh, I think that was the best description of the WHI screw up that I've ever heard, because you got really into detail there. So I appreciate that. I talk about it often, but not in that depth. So I appreciate that. So where does that, like, we see research, for instance, that tamoxifen can help with breast cancer, like without so women don't have a
You just
reoccurrence.
kind of went out. What did you say?
What about this? Like, there's studies that show things like tamoxifen, when taken, can
Okay.
help with the reoccurrence of not getting breast cancer.
Okay, great question. So the idea is tamoxifen an estrogen blocker? If this was really true, why would an estrogen blocker help a woman who's already had breast cancer reduce her risk? What's going on there? Well, first of all, before tamoxifen, which Greg Jordan introduced, before tamoxifen, high dose estrogen was the treatment for metastatic breast cancer, and tamoxifen took over that. So just so you know,
Yeah.
but tamoxifen even helps triple negative, and tamoxifen elevates estrogen in a third of the women actually who take it. So there's a lot of discussion if you do deep dives into the scientific literature on what are the mechanisms that tamoxifen is really being protective. And people don't think it's really that it's an estrogen blocker. But the problem is that MD Anderson, which is the iconic cancer institution in the United States, and presently the Irwin Center is being taken down in Austin because MD Anderson is opening up a satellite clinic here. They now take high-risk young ladies who don't have cancer. Like, let's say you had a lumpy, bumpy breast, you had fibrocystic breast material, and you didn't have a scary mammogram, but when they did the biopsy, it came back with dysplastic tissue, like let's say lobular hyperdysplasia. So you have 12 times now an increased risk of getting breast cancer, which in functional medicine, we would treat at the root cause utilizing things like iodine that oversees and protects the architecture of the breast, and also the use of hormones that are growth controlling when cancer is growth out of control at the breast. But MD Anderson is going to start giving tamoxifen, which does block estrogen, but does many other things. And as I said, it actually elevates estrogen in a certain percentage of women who go on it. But it's ruination for a young woman's life to have your estrogen blocked in your 30s, to just treat you as though you already have cancer to prevent you getting from cancer is a nuts medicine gone on Looney Tunes approach to things, rather than really getting at the root cause, which often can change the physiology and the tissue structure within 3 to 6 months and get a really beneficial outcome, rather than shutting down all the signaling systems that run so many other things, from your vocal cords to your lungs to your kidneys and to your eyeballs. It's not just something that's about sexy and reproductive things. So tamoxifen is not it's an argument that you could put a lot of holes into it. It doesn't mean we never have women that shouldn't be on tamoxifen, but it's not that it just works by blocking estrogen. But that was a great question. I hope that was a great answer to that great question.
Because at its heart, I mean, estrogen is proliferative. And so, I've heard things like, if you've got breast cancer cells in your breast tissue and you're taking estrogen, or you've got your own abundance of estrogen, that this can make it proliferate. True or no?
So first of all, estrogen isn't just proliferative. This whole thing where estrogen, that's where we get wrong.
Yeah.
So estrogen is the oldest hormone on the planet. It was the very first, in fact, in the beginning. So a hormone speaks to a satellite dish called a receptor. And where the hormone is made in an organ, and then it goes in the bloodstream, seeking out tissues with these receptors. It's expert on estrogen and its lineology in cellular and evolutionary development. He was my consultant for my book, Sexy Brain, which threatens environmental castration. And I discussed the threat of gender bending and gender fluidity coming down the road. And that book was published in 2017. But Dr. Baker says estradiol is so complex that in the beginning there was only a receptor, only a satellite dish, and estrogen wasn't even made yet. So a little snippet of testosterone and fat spoke to it, but ultimately estrogen developed more and more satellite dishes, more and more receptors, because it's the oldest hormone. The older the hormone, the more it's been around, the more variety of actions it has in the body, and it does it through diverse receptors. So the first receptor was discovered by Elwood Jensen that I got to work with at Tulane before he passed away. And we call it ER alpha because alpha is the first letter in the alphabet, alpha. And then the second receptor was discovered by Janaki Gustafsson, a scientist from the Karolinska Institute in Sweden, which is kind of Sweden's version of Harvard. And he discovered that when ER beta, it was called beta because it's the second receptor after alpha, when ER beta is signaled, it causes controlled growth. It acts like your own anti-cancer chemotherapeutic agent. Estrogen has at least 12 receptors, if not more. We don't even know all the receptors yet. Hormones are really in a brand new arena. When Elwood Jensen discovered how they worked, people didn't even believe him. Only 3 people showed up at his first convention. But Yanaki has been wooed over to Houston to work with pharmaceutical companies to make breast cancer drugs that act just like that second estrogen signal, which is anti-proliferative. It's anti-proliferative. And then when estrogen is metabolized, if someone can methylate, which means that you have enough carbons and hydrogens around to shuffle the deck of your molecules to make all the different phases of metabolites as your body processes a hormone. Before you make it, you use it and poop it out. Make it, use it, poop it out. So when you're using it and it's being metabolized, you have that second receptor that acts like your own cancer drug and protects you. And then as you methylate and get that third layer of metabolite of estrogen, 2-methoxyestradiol, you have a final metabolite of estrogen that acts almost like a chemotherapeutic medication that cancer patients take. It's so powerful because nature always has balance. So estrogen isn't just driving cancer. Only one of its tiny actions is about growth. Cancer is growth out of control. That's what they're worried is estrogen can cause growth, but estrogen can signal controlled growth and many other things. And people never talk about estrogen in this bigger tapestry understanding of her.
Yeah, in the day 12 estradiol spike. I was talking about the day 12 spike of estradiol and how that upregulates that p53 tumor suppressing enzyme. I mean, that says it alone, doesn't it? Like that when we have this surge of estrogen, that it can actually help with tumor suppression.
Right. And in fact, the 2-methoxyestradiol, one of its main actions is it upregulates tumor suppressor gene p53. P53 is your granddam tumor suppressor gene that's your eyes to your immune system that a cancer cell for some reason showed up in your body, and let's step on it like that glass that Jewish people step on it, in the wedding huppah. You're going to step on that and break that glass. So you want tumor suppressor genes that are activated. And so in multiple levels, estrogen activates that, and iodine helps the second. So you have your parent estrogen that go to your catechol next generation estrogen, which then go to your methylated or your real cancer drug protect you estrogen metabolites. And iodine helps that whole pathway be created. And there's also a movement of fear against iodine. When it's important for every hormone to work and for you to maintain the eyes on your immune system and the ability to fight off a cancer cell that rudely shows up.
Yeah, I interviewed Dr. Brownstein, and I tell you, the amount of feedback I got on that interview was really great. Lots of positive, actually. There was, of course, some negative, and because it's such a hot topic and there's different views on it, but I mean, Dr. Brownstein's been doing this, like he said, for 25 plus years. He's been using iodine in high doses with thousands of patients with really great success. So I'm going to go with his view on it, not someone else's. Now, what about
Well,
estrone?
that's the thing. So we just put on we just put on with four of us doctors, that all four doctors have been using estrogen replacement in their practices
Yeah.
35 plus years.
Yep.
And we've all seen very, very few cases of breast cancer, hardly any, two or three cases of each of us in each practice. And each of those women showed up as better players and responded to treatment and didn't die. They actually were better off for having been on the hormone, which is exactly what the science says. So sorry, I just wanted to make that point. We're
Yeah.
not seeing more breast cancers in practices that use a lot of estrogen, but we do it in balance with other things like iodine, et cetera.
And progesterone and testosterone. Let's talk about how they are breast protective and help to balance that estrogen out.
So we have a cascade of hormones in all men and women. So men sometimes need progesterone, just like women do. Sometimes men need estrogen replacement, like women do. So we all need all hormones just in different amounts, but each one of us has our own individual hormonal footprint. And progesterone is not just a pregnancy hormone. It got its name pro to support gestation. So it's a major hormone during pregnancy, but it's made all throughout the body, all throughout our lifetime. Progesterone is made in 6 different areas in the brain to protect your brain. So progesterone protects against anxiety, protects cognition. It can be used after brain injuries and strokes to reduce the damage or infarct size smaller, quicker. I mean, progesterone's amazing, but what it really does do is it helps protect breast and tissue and the lining of the uterine tissue. That's where it's most known as being a protector of the lining of the uterus tissue. But there are about 70 studies that looked at the level of progesterone in the blood before a woman goes in for breast surgeries, be it a lumpectomy, a mastectomy, or a reconstruction. They looked at the level of progesterone and then followed in many of these studies women another 20 to 25 years. And they discovered that if a woman had at least 4 nanograms per milliliter, like she had enough progesterone to show up pretty well in her blood, those women got less recurrence and died less if they did have recurrence and lived longer with a more successful, safer life, which is what this is all about. So we have so much research that says it's malpractice if you don't check progesterone levels before a woman goes into breast cancer surgery. But none of the research that supports a lot of what we're talking about is really utilized to support the present alarmist, fearful position in most med schools and for hormones. It's really shocking. And I don't ever see anyone going in for breast surgery being told, let's check where your progesterone levels are at. And in the same way, testosterone is also metabolized. Every hormone starts out as its own parent hormone, and then it's broken down into smaller but very active pieces, and those are called metabolites. So testosterone goes from testosterone to dihydrotestosterone to its third little powerful metabolite called 3-beta-diol that signals again that second estrogen receptor that Yanaki Gustafsson said, this is our own way that we fight cancer. And he got wooed over to a pharmaceutical company to try and make a drug that looks like this 3-beta-diol or looks like estriol, which is another form of estrogen that signals, or soy signals that anti-proliferative action at the breast. So a lot of oncologists will tell women, avoid estrogen, don't consume soy, it's estrogenic, but it's the good estrogen. It signals the anti-proliferative, the same exact thing that testosterone does. So nature has backup redundancy systems for protection and safety. So we've got lots of things that signal controlled growth: testosterone, progesterone, a lot of botanicals. Yanaki did a lot of research in the beginning when he discovered ER beta. He showed that milk thistle and apigenin, especially from organic dried parsley and celery and oat flour and flax seeds signaled ER beta, and that was what his original research was based on, were natural agonists or signalers of ER beta, showing that they fought against breast cancer. Soy is included in that. Soy isoflavones are the only food isoflavones that definitively signal that protective second chemotherapeutic-like estrogen receptor, so much so that there's no debate anymore. There's no debate in the literature. It's massive amounts of epidemiologic and also human literature that shows that soy is breast protective. And it used to be thought, well, you had to be raised in Asia and be consuming the soy from early on. Now, more recent trials show that if you're an American woman and you get diagnosed with breast cancer and you hear a podcast like this and you go, oh, I thought soy was bad for me, I think now I'll try some. And you go on soy nuts and miso and some soy tofu, you reduce your risk of recurrence and you reduce your risk of death if you do get recurrence. So there's so many things to do to keep you safe. And once you've had breast cancer, as I've had, I had breast cancer 30 years ago. I had another cancer because my mother was given a synthetic endocrine disruptor. That's a whole nother story. But I've been on bioidentical hormones after breast cancer now for 28 years. And so I love to specialize in treating breast cancer patients. And I always say to all of my patients, you want to make your remission your mission. And that's partially done with hormones, with foods, with botanicals. It's body, mind, spirit. You know, you have to train for your remission like you're training for an Ironman, because you want to be fit as you could possibly be. And I don't know how you are in Canada, but if you look out at the American public, we're unfit, we're overweight, we look really, really ill. And a lot of staying well and safe is getting fit. So
now we have, knowing all of this information, we've got all of this research that backs up that estrogen is not causing breast cancer. It is not the cause of breast cancer, period, end of story. And yet we're still seeing so many hormone practitioners. I see it online every day, functional medicine practitioners who are stating things like this, that, estrogen in the WHI study, they state that, what you just talked about, how the two
it's
different
ignorance.
arms of the
They
study,
don't know that, they don't know the research. They're just parroting what they've heard, and in Mercola's article, the gentleman, I even hate to call him that he interviewed, called estrogen an exotoxin. That's what he called it. And it's not an exotoxin. In fact, I was just lecturing at A4M in Vegas. It's the largest anti-aging conference in the world. I was the oldest speaker because I just turned 75 when I lectured there.
You look
amazing.
And
thank you. There were 5,500 medical doctors there. And so there were 30 speakers that got to speak in the big room that was like a football field. And half of the speakers said estrogen protects. It's a great anti-aging tool. Hormones are a great anti-aging tool for men and women. The other half of the speakers, who were educated MDs that were invited to speak there, said estrogen drives breast cancer, hormones accelerate aging. And so half the speakers were pro-hormone, and they were all functional medicine docs, and half the speakers were anti-hormones. And that's why 2 weeks ago I put on the talk, which I'd love to have you share with your listenership, the Let's Talk Estrogen. We invited people who had the opposite opinion of estrogen to come on, and they did not choose to come on, only the docs that were pro. And in fact, one of my real iconic figures, because she's done so much for the protective role of testosterone in breast cancer patients, I sent her a summary of slides that I had done a presentation at the International College of Integrative Medicine in Dearborn, Michigan 2 years ago on the 26 studies where they gave estrogen to breast cancer patients that were ER positive, and they were mild and moderate cases. There were 26 studies. One was 30 years long. One was 24 years long. They all had matched cohorts, a group of women who weren't on estrogen, and they could compare them. One study was by MD Anderson. One study was by the University of Wisconsin. One study was by the University of Georgia. I think a few studies were outliers that were not on the United States mainland. In not one study did women with breast cancer, ER positive, taking estrogen do worse. It was exactly the same thing. They had a higher quality of life. They had less recurrence. And if they did have recurrence, they had less fatality. That echoes through the science, but that's not what we're hearing from the doctors who really don't have their hand on any of this data and information, which is why I so appreciate the opportunity. And I hope I'm not giving out too much information at once to be overwhelming. I'm just so passionate to get correct information out. So I'm going to try.
I'm just as passionate. Don't you worry.
I know you are. Thank you.
I get on my soapbox and I don't shut up about it. But yeah, I just want I want not just MDs to know this, but functional practitioners to know this, because I am always hearing like these people that have like breast cancer podcasts and they're breast cancer oncologists. And they talk about, well, we can give it to you. We can give you estrogen in your vagina, and that's safe to take if you had breast cancer. And that's just not like, we can be giving this to women systemically, which will also help to ward off heart disease, which is a major killer of women, far more than breast cancer is.
Right. 1 out of 3 women die of heart disease and 1 out of 25 women die of breast cancer. But you can also give hormones vaginally and get them to go systemically. So in all the studies starting out with the Finnish studies, the famous study in 2008 in ACOG from the Finnish PhD student, where she looked at, she tracked 114,000 women for almost 20 years. And women who took estrogen vaginally never had an increased risk of breast cancer. The same with that new 7 million NIH trial when they looked at different delivery modes. How do you get the hormone in you? You know, oral versus on your skin, topical versus in your mucosal membrane vaginally. The women who took hormones vaginally had better off of every single thing. So, but then you have to do it in a different way than just tiny little amounts to lubricate the vagina. It's a totally different delivery mode, which, by the way, Dr. Brownstein and I were so upset with the lay of the land, with so many people bad-mouthing hormones and yet not understanding the science, and so many patients missing out. My sisters of the heart, my breast cancer sisters, you know, people say, how do you act and be who you are? And of course, every single doctor would say, if you've had breast cancer, you're never a candidate for hormones. You cannot be on hormones. And it's really not accurate for all patients at all times. So we've decided to put on our very first online course on hormones for practitioners. And I always lecture for other people's CMEs, but now this is our own CME course, and it's online. So you can do it when we're doing it live, or you can take it anytime you want, but it's 16 hours of CME for MDs, nurse practitioners, nurses, PAs, and naturopaths. And I think it's also possible for some pharmacists. We have the CEU board that we use. You have to check in with your CEU board, but we want to let people know what is the reality of it and how do you really do this, and what is the dosing, and what are the bases and the different form of bases. And if you do give it to the vagina and you want the vagina to be systemic, what are your variations that you do that? And so we're going to make it Monday morning ready with all of this information. It's called Everything Hormones, and it's the first time that we've done it. It's mostly being taught by Dr. David Brownstein, a world expert on hormones with best-selling books out on it, and a hell of a wonderful guy, kind of like my brother. We've turned out to be more brother and sister, 2 peas in a pod kind of people. And then we also have as guests who know so much, Dr. Anna DeRosa, who's going to talk about what tests you run to know that the doctor is giving the right amount of hormone to get the deep tissue response, like your memory piggy bank, your hippocampus. Are your hormones that you are taking revolumizing and protecting your hippocampus, which in all dementia-like diseases shrinks, and we want to keep it not shrunk. And she's going to teach us how to do that. And then we have Dr. Carol Peterson, a doctor of compounding pharmacy, who has been the world's expert of progesterone, the ins and outs and the misunderstandings of dosages and delivery modes. And so it's going to be a very exciting conference.
Very exciting. And can anybody take your course, or only licensed medical professionals?
That's a great question. Anybody can take the course.
Great.
But if you're licensed, you get the CEUs, but anybody can take it. And we were kind of debating, should we give it for a lower price if people aren't going to get CEUs? But then we thought, well,
Mhm.
people might do that. You don't know how to control for a variety of factors, but we also have with this course that we have follow-up evenings of Q&A and then personal discussions of case reports, because whenever you learn something and you go to your back home to your practice, it might not act like the way you were taught it should. So we're going to have follow-up with availability to myself and Dr. Brownstein to help you keep on track. And if you something didn't work out the way that we suggested it might, we can process it with your patients. So there's not only the 16 hours of CEU, but there's also some follow-up.
Great. And I know that my listeners are going to be happy to hear this because I get asked constantly, what course do you recommend, Karen? And I'm like, oh, unfortunately, I haven't come across too many great ones. I know Dr. Felice Gersh has a really good one that I took. And so I usually send people to that one, but it's only
The
2 hours. So it's a
holy
very,
grail of anti-aging is the volume of the hippocampus. So they said, let's look at exercise and meditation. Hey, that those should do it. So they just published the results of their 2-year huge trial called MedX trial, Med for meditation and X for exercise, showing that 2 years of intensive exercise and meditation did nothing to reboot the volume of the hippocampus, because it's mainly estrogen and testosterone and the nutrients
wow.
that allow them to signal. So I think that will be what takes us when we get to that appreciation of the hippocampal volume. And I would love,
Yeah.
hopefully in the next year, to do a study where we give hormones and we track the size of the hippocampus with functional MRIs and show that we can reboot within a few weeks to a few months that nothing else can do. I think that'll put and it's done with estradiol equivalents, not
Yes.
estriol. And that's
Yeah.
why you need a
And
lot
the
of that.
bone protection, it shows that it's estradiol. If you get it up to 65 picograms or higher, that's where you get the bone protection, not estriol. And so I just think that there just needs to be, we need to change this conversation around biest or estradiol. And it's more so, let's remember the importance of estradiol and what it does and not be so fearful of it.
So all your nutrients, the reason you want to eat a good diet and you want to digest it well, is that the basic players that you digest your food choices down to, those end up sitting in the parking space where a hormone wants to park into a satellite dish. And the hormone, no matter how perfect your level is, won't be able to signal unless the nutrients are there. So you need zinc and
Mhm.
magnesium and B6 and vitamin A and a variety of other things all sitting in the satellite dish, and they make a difference. So, a lot of times someone will say, well, I tested my hormones and they're perfect, but I still don't feel good. But the
Yeah.
hormones aren't really able to signal. The receptors got to be available. They can't be endocrine disrupting compounds like plastics and heavy metals and volatile organic pollutants squatting on those receptors, which is why I created my new line, Biotics, called Receptor Detox. And then you need all the nutrients. So it turns out that hormones are this larger tapestry, yet in medicine, we're used to algorithmic. You test this, and what do you give this for that, rather than looking at the bigger picture. So most of the time, people are tested for the levels and they go by those, which aren't enough because you don't know
Mhm.
if the receptor is functional. And the other thing is, a lot of times people are tested. A man will come in and say, I went to my doctor and he said, I'm fine for a guy my age. And that's just the deal. You want your reference range to be if you want to use hormones to make you younger, longer, safer, longer, you want the reference ranges to be when you're in your 30s, where you were in your 30s, not your reference range of your age presently.
Mhm.
And
Yes.
that gets a lot of people not being able to get scripts for hormones because their doctor says, well, you're
Yeah.
65 and your hormones at the level of a 65-year-old guy, so you're okay.
Yeah, women are told that all the time too. Oh, well, you're right on target for your menopausal age. You got 0. Okay, now as we wrap things up, there is one thing that Mercola and them kept talking about, which was that estrogen is anti-metabolic. And I interviewed Susan Wadia. Do you know her? She wrote the breast
No.
cancer book.
No.
So she's done 10 years of research on breast cancer, and her final conclusion was it is a metabolic disease. And we know that estrogen, which, it's obviously more complicated than that, but we know that estrogen is pro-metabolic in the right amount, that this is
What
why.
exactly do you mean? What are you saying exactly? Because everything's metabolic. So, I mean, not
So
everything's metabolic. So what exactly do you mean that estrogen is metabolic? What in your mind, what are you thinking
that
in your
it
mind?
supports the metabolism, it supports blood sugar, it supports
Oh,
insulin
I see what
sensitivity.
you're saying.
So for the metabolism, it's positive if it's in the right amount. And a lot of people, like Merkla and them, that they were talking about, is that they think it's, estrogen's going to make them fat. And for sure, too much estrogen can, but too little estrogen will cause more weight gain in my eyes than too much estrogen.
Estrogen sensitizes the insulin receptor. If more women were on estrogen, we'd have less type 2 diabetics. Whoever's saying that is somewhat of an idiot. I'm sorry. I'm
Thank
so
you.
done with all this stuff. In fact, the opening of my book, Safe Hormones, Smart Women, I do the quote of Dr. Salter, who talks about how she prophesizes there'd be 85% less type 2 diabetes if more people, when men were becoming andropausal and women becoming perimenopausal, if we were put on hormones, because hormones make all the other hormones work better. Estrogen makes your blood sugar work better. You really only gain weight from estrogen if you're getting more growth signals out of balance with controlled growth signals, or often not enough progesterone, because so Katerina Dalton was really one of the very first physicians in Britain who made the whole hormone revolution in the 50s in Britain. And she was taking women who were up for going to jail for a lifetime imprisonment. Uh, what? So
For
they,
homicide, right?
for killing their husband, for
Yeah.
shaking their baby to death, for uh, starting arson and having fire. She had a whole slew. She was a forensic medical testifier, and she was able to show that it was because these women had much higher needs for progesterone in the second part of their cycle. And she was the doctor that came up with the term premenstrual syndrome, first based on these women with very aberrant behavior, not just, growly and, all the jokes that are about PMS, but PMS on roids, where women really have aberrant social behavior to the point where they might end up committing murder. And she was able to get a lot of women off. And the doses, the bottom line of what I'm trying to get at, sorry about that, is the doses. She used doses from 300 to 900 to 1200 milligrams of progesterone. And
Mhm.
when we have Carol Peterson on, she's going to be part of our Everything hormonal. She talks, and she was the main compounder, pharmacist at the world-renowned Women's International compounding facility in Colorado here in the United States for 25 years. And what she's seen is that to keep weight off when you're on hormones, part of the beautiful sweet spot of the mix is having adequate enough progesterone. But I think in England, a doctor can't even legally prescribe over 200 milligrams now, even though Katerina Dalton was the first English physician that was using such high doses. But it's the balance of hormones. And it usually means if you're gaining weight on hormones, that your hormones are out of balance. And the most common thing is not enough progesterone, which calms the system down, narrows the waist. And if your breasts are getting larger from replacement, gets them closer to your typical cup size. So a lot of it is misunderstanding, but I just learned from Carol speaking to my group the other evening that in Britain, doctors can't even prescribe over 200 milligrams of progesterone a day.
Oral
And
progesterone, right?
oral,
Are
yeah,
you talking about
that's,
oral?
I think it's any kind. I
Okay.
don't
Yeah.
know. I don't really know. This was the first time I heard it. So I don't know.
Yeah.
We don't have that in the United States where we're limited by doses, although do you have that in Canada?
No, we don't have limits. No. But I wouldn't, I definitely, with just clinical experience, over 200 milligrams of oral progesterone, even 200, I run into a lot of problems because of the metabolites. A lot
So
of
it's
women get
interesting.
depressed.
So I'm now part of the Institute of Bioidentical Hormones, and it's all these doctors who've been in hormones for 30, 35 years, and the average dosing. So I was typically giving oral about 150, 175, 200.
Yes,
The
same.
average dose in this group is 300 to several thousand.
Yeah, which
And
I
they are
can't
getting,
imagine.
so I guess the bottom line of all of this is there is no set understanding of
There
hormones.
isn't, no.
Nobody's got the last answer.
And that
There's
everybody's
It's
different. Everybody
evolving,
needs something
but they're
different.
not, they do not drive cancer. Most of the research shows that estrogen protects against it. And the WHI, the estrogen only arm, by the very authors who started the WHI, which was meant to say, how do we keep women healthy so we don't topple Medicare, came out and said estrogen is a breast protector more than anything we've ever seen before. Why
Wow.
is that message not out there?
Exactly. Yeah. And you talk about in your progesterone webinar, and I've looked at this research, which is that oral progesterone, and this is only one research paper, but past 200 milligrams can cause inflammation of the breast tissue.
That's from the a Canadian
Yeah,
biologist, Weeb, actually.
Canadian.
And
Yeah.
so that is really, so that's the understanding that progesterone has metabolites, and some can be pro-inflammatory and some can be anti-inflammatory. So after that, Jonathan Wright at Meridian started to run a lab where you could run those two metabolites. And I used those for several years in practice, and it took me nowhere. So I went away with following that thinking. That's what happens in medicine. You hear a researcher, you try
Yeah.
and translate it into the clinical trenches, and then you see over the tincture of time, did this work or not work? That did not work for me at all. And I have
Mhm.
now found that higher doses of progesterone work, and that more of a balance of everything. So I was more timorous with my doses of progesterone based on Weeb's work. Now, mind you, he's a biologist, not a clinician. Same thing with the person that Mercola interviewed. He was
Mhm.
a scientist, not a clinician. He wasn't even a hormonal clinician, but nonetheless. So we are evolving in our understanding. And the bottom line
Mhm.
is that every person has their own needs and how they respond to things. And if you start getting where you feel bloated or depressed, or you start feeling a way you certainly don't want to feel, then that needs to be tweaked. And sometimes it means taking less, and sometimes it actually, as counterintuitive as it seems, means taking more. But it's
Mhm.
working with a doctor that's open to trying to see what's the best dosing for you.
All right, I'm going to let you go, Dr. Berkson, because we are over time, and I appreciate your time so much. Thank you so much for coming on the
Okay. I hope I haven't
podcast.
been too argumentative or something.
Hey, I invite argumentativeness, argumentative people. No, no, it's been great. It's been very eye-opening. I appreciate all this information. I'm excited to share your webinar with all these
I
other
love
people.
it. This is
And
really good
then
because
this
this is the
roundtable that
way
we're going to
hormones are.
have.
Sign me up.
All right. All right. Thank you so much for
Thank
coming
you
on
for
the
this
show.
opportunity. I wonder if your audience is out there giggling their heads off. Okay.